And we're live. Welcome back to yet another episode of Professor and the Idiot. I'm Nick Wolfinger.
I'm Amy Newberg. I'm the idiot.
And that just can't pass without some reaction on my part.
I know. The best part of our podcast is me being able to say those words.
And today we are very pleased to have Amy introduce today's guest.
Okay. Today's guest is Roger Halston, and Roger is a speech and language pathologist working in an Albany school. I met Roger because we both enjoy the Sunday hippy dippy freestyle dance that we've been doing for many years at Ashkenaz, which is now online, and learned that he was a speech and language pathologist, which interests me very much because I'm sort of an amateur linguistics, I don't know what you'd call it, aficionado, I suppose. Having studied it back when I was in college, I have a degree in linguistics in addition to music, and I don't really know what's happened in linguistics since then, but maybe Roger can tell us. So anyway, issues of speech and language and vocalisms and all that stuff are really interesting to me. So we invited Roger on. Hello, Roger.
Hello.
So what is the school that you're at?
I'm at Albany Middle School.
Is that a public school?
Yes. I've worked there in that district for about 11 years now.
Okay. And can you tell us what a speech pathologist is?
A person that works with communication disorders and deals with language issues and also with articulation issues like making specific sounds like R, like instead of Roger saying Waja, which is what I did when I was a child. And it also deals with voice disorders that might be due to, like throat cancer, for example. And it also, because speech pathologists work with the vocal tract, we've also gotten into the field of swallowing disorders. So when I worked in skilled nursing facilities doing analysis of whether patients were at risk for aspiration, choking on their food or other secretions in their mouth, that would be another thing that in a medical setting, speech pathologists often work with.
So it's pretty wide ranging, actually.
It is.
It's a lot more than just speech. Yeah.
Yeah.
And how did you get started doing this?
Well, I originally was studying architecture, and after a couple of years of that, I decided that was not going to be what I wanted to do. And so I went to the career counseling on campus, and they gave me some tests, and those tests came up with the idea of speech pathology. The test that gave me the idea was the Strong Campbell Interest Inventory Survey, which I recently heard somebody say they took in the last, recent years. So it's still being used, I guess. And that's a test that asks people a bunch of questions about what they like to do. Would you like to add up numbers? Yes or no? Would you like to walk on the edge of a cliff? If you're at a dinner party, would you want to sit next to the guest of honor? Just a whole variety of different questions. And they've given these questions to people in a whole bunch of different professions or job categories, shall I say. And so they figure out what the pattern of responses is for a given job category. And then when I took the test, I was matched up with several different possible careers. And when I looked into the speech pathology, I thought, yeah, that's something I'd like to do. So I've been doing it since.
Where did you study speech pathology?
Undergraduate, UC Santa Barbara, and then for master's at University of Washington in Seattle.
It sounds like you've had a number of different kinds of jobs along the way before you settled on working with children. Is that right?
Yeah. When I originally went to grad school, my idea was that I wanted to work with neurological disorders because I think the mind is a pretty awesome thing. So for the first few years after I entered the field, I was working with adults and in medical setting, as well as working with kids. And after a few years, I realized, I really just have more fun with the kids. And so that's where I focused after a while. But I still had the idea that I like to keep my doors open. And so after a few years after I was no longer working with adults, I did go to a workshop to try to keep up my skills working in the medical setting. And I realized at the workshop, I have no idea what they're talking about half the time. I should not work in that area anymore. So that was kind of the last I did with adults.
Why wouldn't it be the same way with kids? Why isn't it?
I'd say that the two big areas of employment, well, there's being an academic, teaching people and doing research, teaching people to be speech therapists and working in that field. The other two big settings are the schools and then the medical setting. And if you're doing things in a medical setting, then it's focused upon different acquired disorders, largely. Stroke patients with aphasia, loss of language, or people with cancer of the vocal tract, which means everything from the lips to the lungs, that whole area that the air flows through. And also injuries like closed head injuries or otherwise. Various kinds of medical disorders require a certain skill set that's going to be different than working in a school setting, where typically the speech therapists focus on more the educational aspects of training children how to be competent adults.
So in working with children, do you notice like preponderance of certain kinds of disorders, or what are the things you see most often in children?
Well, with kids, the sort of simplest thing is just the articulation disorders. So teaching a kid who's lisping how to make a proper S sound. And the approach there is largely one of behavior modification, where you first get them to be able to make the sound in isolation. You just want to get them to be able to produce it by giving them instructions about how to move their mouth, and maybe even using like a tongue depressor to touch the part of the mouth that you want them to be moving. There are different techniques there. And then once they are producing the sound, the behavior modification technique is that you just reinforce the appropriate approximations of the behavior you want. So you encourage them by giving them verbal reinforcement, just praising them when they're successful, or maybe having, when they earn 5 stickers, they get to have a play break, or, whatever is reinforcing for that kid.
How do you know, at what age do you know that this is definitely a disorder and not just some kind of slow development thing? I mean, kids all speak badly. They all, they whine and they can't pronounce things correctly, and they're hard to understand. And then at some point, I guess you notice, okay, everybody else is speaking a certain way and this kid is not. So how do you know when to intervene?
Yeah, for sure. The baby on Family Guy who speaks with a British accent with perfect elocution is not normal.
But would you see a problem there if Stuart Griffin were your kid? Aside from his matricidal tendencies.
That baby is not normal because he's above the normal range.
Right.
And that's actually a whole nother subtopic of this is the very term speech pathology means the science of disease, the word pathologies, the science of disease. And so it's based in a model of looking for disorders and then remediating the disorders. There's one attitude that says that we should focus more upon what is successful and functional and just work on expanding upon that without being as concerned about labeling things as being disordered. When you got a medical model, it's all about Where's the disease? Let's fix it. And I guess the public health approach to things is looking at a population. Where can we get better performance, better outcomes, rather than necessarily focusing on where is there an acute disease. Instead, the public health model is, let's just make sure everybody has clean water and a lead-free environment. But there again, that's a whole nother kind of tangent. We could go
I
off there.
extend the metaphor a little more and say, for example, one approach that isn't adequately practiced in the United States is wellness, right? How can we keep people healthy? But I'm struggling to see what the speech pathology analog is to that.
It sounds like the idea is, don't diseaseify this thing and make the kid feel like he's abnormal, right? It's like, just work with what the kid has and make sure that at least he's healthy and getting a proper education. And I don't know, it's sort of like when you teach singing, you can only teach to the basic talent that the person already has. You can't really give a person more talent. So you help the person find like her natural voice, and you work with that, and that's the person's voice, right? And she just has to be comfortable with that voice. So it sounds kind of like that's what you're talking about.
Yeah. Nick, did you want to say something?
Yeah, I was going to question, I mean, certainly there's a world of improvement in medical communication that I'm just questioning how the kid's speech is fucked up or it isn't. I'm just having trouble extending the metaphor, the wellness metaphor.
Well, what I would say is that the way that things are currently structured, for me to provide services in the public schools, I need to diagnose a disorder.
Right.
Specifically, it's called a handicapping condition by law. Right. There's a certain set of about a dozen handicapping conditions, and speech language disorder is one of those. Speech language impairment, that's the phrase, at least used here in the Bay Area here. But it is a problem in that it can be hurtful to a child to be told they have a handicap, that there's something wrong with them. It would be better if they didn't have to have that label put on them and could still get help. This is a huge problem because we're such a litigious society that you've got the school district who in all good faith may be trying and wanting to provide services, but they have to follow rules about it. And then the parents have, reasonably enough, the right to sue if they don't feel the rules are being followed with their child. So I guess what I would say is if we had more trust in this society, then we wouldn't have to be so litigious. We wouldn't have to rely upon huge resources being used in trying to document that you've done what's legally required and fighting over whether or not the law was followed. And we could instead just focus on providing the services we could.
That makes sense to me.
Yeah. Can we get back to it?
Okay.
Like the thing I asked earlier about
yes,
sort of the window of time when at the beginning you know that the child has a problem. Is there a particular age when that begins? And then by what age should you have addressed the child's issue such that it can actually be helped? I mean, I imagine like learning a language, there's a point when it's too late.
Yes and no. A big part of what diagnosis is all about is, does this child meet the norms for their age or not for that particular behavior, whatever the specific thing is that you're examining, whether it's vocabulary acquisition or a combination of words grammatically, or whether it's articulation, whether it's social skills in use of language appropriately. Each thing has different norms for acquisition.
So at a certain age, a child should be able to make the R sound, and at some other age, a child should have a certain kind of vocabulary, and you're really
Yeah.
you're dealing with matters from the physiology of the vocal tract to learning disorders.
Yes.
So that's actually kind of a multifaceted
Yeah,
discipline.
it is. Yeah. Speech language pathologists working in the schools um, do so under special education law. And that determination is by law made by a team of people. It's the speech therapist, it's the parent, it's the teacher, it's an administrator of the school, and often it will include a school psychologist or a whole variety of other professional titles might get involved, where each person comes with their perspective on it and whatever assessment they may have made prior to the meeting.
And is it generally successful?
Intervention?
Yeah, is this I mean, do you really notice the kids improving? You know, what if the kid is older and still having this problem? Is it still addressable? What if the kid has it all the way into adulthood? Can you still address the problem?
Well, it varies a lot. There's some things like, for instance, a simple articulation disorder. Kid hasn't learned to pronounce S correctly. In almost all cases, that can be corrected where they can be exited from special ed and they're fine. When, however, it is something that involves language in some way, that is often a much more pervasive problem and may be one that will persist into adulthood.
Because that's a learning disability that probably will always exist. Yeah.
In many cases, it is, because language is such an integral part of your overall cognition that if you've got a language disorder, in many cases you will have persistent issues in life in other ways.
And does reading tie in with that at all?
Certainly it does. Yeah.
I mean, is that something you work on? Do you work with dyslexic kids, or is that a whole different?
I do sometimes. Most often I defer to another job title, which is reading specialists, because that's their bread and butter. They work on it all the time. So they're the real specialists in that. But occasionally I do work with kids who are dyslexic if I'm working with a student, maybe on having them be able to understand a text and be able to make inferences about the text. That's a language behavior. But if while we're reading along, they are having difficulty with some letters, I'm going to help them out with that.
Have you seen any just really difficult problems that stand out in your mind, or that you were not able to address, or were, really unusual in some way?
Well, I would say that there are a lot of students who have problems that will persist into adulthood that I can still address in some way. I can maybe make it less intensive a problem, make them a little more functional in that area. That might be by actually increasing their ability to combine words into sentences. But sometimes what I can offer is instead compensatory strategies. I can't change their basic neurological functioning, but maybe I can help them find ways to live with that handicap in a more functional way.
Do you think that, because you've been doing this for some time, maybe you've seen some trends, we didn't have speech pathologists in the schools when I was growing up?
I did.
Oh, you did?
Yes.
Oh, okay. So I mean, I'm just wondering are we just noticing this more, or do you think that kids are different now than they were? Like we just are seeing more cases of kids needing this kind of therapy?
Well, I was wondering at first, Amy, just where did you grow up?
Mostly in Maryland,
Okay.
near Washington, D.C.
Uh-huh. Okay. Well, my guess is that they did have speech therapists in the schools there in the district you went to school. They probably did, but you had no reason to know it.
Oh, okay.
This
I
is
know.
particularly of those of unpathological speech.
Yeah, I have a pretty low profile at my school. I mean, among the kids. I mean, they may see me in the hallway or they may notice my office off the corridor, but I don't draw a lot of attention to myself because I don't want the students I work with to get any extra attention.
Right.
They don't want to identify you as the guy you get sent to when you talk funny.
Yeah.
As was the case with me. I saw a speech pathologist.
Uh-huh.
Oh, you did?
Yeah.
What was your problem?
You mean, what was my speech problem?
Yeah.
So this was at Thousand Oaks Elementary School in Berkeley in the early 70s, where one of my classmates was Kamala Harris, although she was a couple of years ahead of me. My problem in the second grade, they noticed I could not pronounce TH properly. The house, there, she, etc. And so they pulled me out of class, and I said once a week, and I saw a speech pathologist. And now, your people did good work because now I can TH like a pro.
Yeah.
Oh, wow.
Yeah.
May I jump in for a second? And I promise I'll move
Jodie.
I've been listening in.
Wait.
Okay. I forgot to tell our 5 podcast listeners that Jodie Balter is studying speech pathology, and we have invited her to come and join us and learn from Roger and ask whatever questions she would like to ask. Well, here's Jodie. Hi, Jodie.
Hi, everybody. I'm just wondering with Nick and to ask Roger how, there's a developmental age after which it's abnormal or, atypical for kids to fail to pronounce certain sounds. And I'm wondering how old you were, Nick, and
7.
and Roger, whether that's something Nick might have just developed on his own.
He may, without intervention, have developed the TH sound, but if you haven't, I don't know. I would say that if you haven't got the TH sound by age, let's say 12, then it's unlikely you're going to get it without intervention.
Yeah.
I'm sure it's a matter of percentages that certain percent of 7-year-olds that don't have it will spontaneously acquire it, and it falls to, I would think, close to 0 by the time you're 12.
Yeah.
I have one last thing I wanted to bring up before we go to Nick's questions and Jodie's questions, which is that there's so many now non-native English speaking kids in the schools that it seems like that must sort of confuse your work somewhat, because it's hard to know what is some sort of disability in learning language and how much is just the learning of English as a new language, and how do those things intersect and confuse each other.
Right. That, again, is a very active area to consider when you're figuring out a assessment. And one thing we do is to find out whether English is a first language for the child. If it's a second language for the child, sorry, I got a phone call.
Oh, that's very pretty.
I don't need to take the call. It's just that I can't turn off the phone. I'm sorry.
That's right.
What were we talking about?
Oh, non-native English speaking kids.
Okay. Yeah. If a child is first language English, then you figure that any other language they speak, it shouldn't be an explanation for anything you see. If they're acquiring multiple languages at the same time, or if English is a second language, then you need to consider how much of an impact that other language might have. If, let's say it's an R sound. If their first language was a language without an R, and they didn't start learning English until they were maybe 5 years old when they started kindergarten, then you would probably conclude that the lack of the R was a foreign accent and not a disorder. And so you probably would conclude, okay, I'm not going to treat that.
Who are the poor, benighted people who stagger through life without the benefit of an R sound?
Yeah.
Terry Jones from the,
I think Nick might
Python
mean
crew.
what language lacks an R.
Yeah.
Oh, I was just thinking of adults I knew that, there are adults who, right.
There are a number of languages that don't have R, but I'm not going to, I don't want to go on record saying which ones they are. I'm going to check.
The American R is really pretty specific to the American version of English. I mean, even the British R doesn't sound like ours. And of course, the Spanish and French R's are totally different. So it's, it's actually a kind of a hard sound for other cultures to master.
Yeah. And honestly, see, again, because speech pathology in the schools is conceived of as remediation of a handicapping condition, it's considered inappropriate, even unethical, one could even say, to treat somebody for an R if their mother tongue didn't have an R. But I am not totally convinced of that personally, because it seems to me, I mean, I've got 2 kids on my caseload right now. I'm treating the R for one, and I'm not treating the R for the other. And the reason is, one of the kids, they're both born in this country, I think, but one of the kids came from an English-speaking home, and the other one is from a home that is not English-speaking. And so the one from the non-English-speaking home is going to grow up without an R and go through life without an R. And it seems to me, well, that's not really fair. And yet, the logic of it is, it's wrong to label them as disordered. So it's sort of between a rock and a hard place. My inclination is to think, and I really think that this is a touchstone that people in the human services generally adhere to, is what is in the client's best interest. Advocate for the client. If you think it's best for that child to get a service, then go ahead and offer it, go ahead and do it, and don't worry too much about arguments for why you shouldn't do what's best for that child. At least talk to the parents about it and offer what you think would be best for that child. This is a student that's just been on my caseload for a month, and we're dealing with so much else right now during COVID that I haven't addressed the parents about this. With this one student on my caseload that I'm not treating the R.
Jodie, are you thinking you might work with children?
I went into this thinking I wanted to work with adults, and I was not prepared for how much fun it is working with kids. I'm doing my clinical practicum, my school-based practicum right now, and these kids it's my favorite thing. I'm in the most overwhelming semester because it's compressed and we had no break after our compressed summer semester, and yet I'm enjoying getting on the Zoom therapy room every day and working with these kids. So the answer is maybe. I'm really enjoying it, to my surprise.
Yeah, that pretty much is my experience. I first was going to work with adults and then realized that kids are they generally are more cute.
Well, they are very cute. Some of these kids are unbelievably cute, but they're also just compelling. They're fascinating. Well, and the other subspecialty, I guess you might call it, in the field that might be my jam would be working in voice. And I think it would be really interesting also to work with, say, transgender adults and voice disorders. And that's adults, but most of the adult populations that people work with are very ill, or they've had strokes or brain injuries, or they can't swallow properly. And that's not as much fun as playing games with kids.
Yeah.
See, and all the little psychological problems and the dramas and the different things they like and don't like, and how excited they get when they do well, and how excited I get when someone who has no ability to focus, when I crack the code and get him to focus for the whole session. It's really compelling.
It is. It's really satisfying when you feel like you're connecting and able to make an improvement.
Yeah, I'm starting to think it might be cool to work with kids and have sort of a side hustle working with transgender voice at some point, because I do find I'm drawn to that too, and that and other areas of voice as well. Possibly for whatever reason, I find that really interesting as well.
So one thing I learned from Jodie about the transgender voice is that although if a man is transitioning to woman, she takes hormones, and many physical things can change from the hormones, but actually the hormones do not affect the voice.
Right.
So there's a certain thickness of the vocal cords and a certain sort of set of resonant cavities in the vocal production tract that just can't change with hormones, and those are going to make that person always sound like a man when speaking. So that has to be kind of a forced change.
If they decide to do that, of course, there's also a movement afoot among some subset of the population who are all about sort of owning their voice as it is and not trying to change it. But it actually can be a literal safety issue for a lot of trans women to have more masculine voices. It can be, they're victims of violence at an incredibly high rate. So a lot of them, for their own safety, want to, quote, pass.
So wait, it's safer to pass.
Yeah.
So that there's not confusion about being transgender. I see. Okay. I was thinking it might be safer to retain the male voice so that you could say, hey, man, I'm actually a man.
No, I mean, I think
look out for me.
Yeah. I think the perception is that if they're perceived as a woman and then suddenly something gives them away, people still freak out about that, and in some cases freak out violently, which is messed up, but it is the way it is. And then of course the converse, I think I mentioned this when we were talking about it, is that when it's a female to male transgender, the female hormones often will thicken the female to male person's vocal folds, and they will, after a year or so on the hormones, will sound like a man or have much deeper voice. So with female to male, hormones do have that effect.
Nick, you've got a big list of questions here. Do you want to get to any of them?
Oh, yes. I think some of them I answered because I got a chance to bring up my own experience seeing a speech pathologist. I think the one question that I really would love to hear from Roger on is about America's most famous stutterer, and that's Joe Biden. Many people were speculating that he was suffering the early stages of dementia, and then a few months ago that article in the Atlantic came out by a linguist which suggested that no, Biden's always had a stutter, and just as he gets older and he loses the physical force necessary to suppress his stutter, and that's what we're seeing when he seems to stammer or some word salad comes out of his mouth. Do you like that take? Is that a reasonable conclusion?
I have not heard that before. I haven't read anything about Biden's speech, actually, so I don't know anything about what he might be experiencing. But it's new to me to hear that stuttering would manifest differently, if I may say, in the geriatric population.
Same here. I've had a couple stuttering classes, and that never came up.
My dad had a speech. He had an interesting way of stuttering in which he would kind of swallow his stutter, and you would just see his mouth move for a little while before he made the sound.
That's the block.
He was like looking for the words, and he wasn't making any stuttering sound. He would just sort of, his mouth would tremble a little bit, and then he'd finally speak, and then he would speak beautifully. Like he had this like amazing poetic way of speaking. And that did not change as he got older. Didn't get worse, didn't get better.
Yeah, I don't really have any insight on what may be going on with Biden.
I haven't really noticed it. I mean, I've noticed that he doesn't always speak in coherent sentences, or he has some trouble thinking of the next word to say, but it doesn't seem like a stutter to me. It just seems like he's not one of those sort of silver-tongued sentence makers.
But I would say this, as long as we're in this election cycle, that I think Trump is probably the worst speaker.
Oh, yeah.
He's certainly no better than Biden.
No, it seems
Oh.
cognitive in his case.
Yeah, he can't form a complete sentence and seems to have a vocabulary of like 5 words. Yeah.
I still laugh at the time he was trying to commend military service dogs and said, "This is a very special kind of canine. I call them dogs."
I never heard that, but that is
that was my favorite.
an instant classic.
Yeah.
No, I was just saying he substitutes words. He gropes for weird substitutions and calls things the wrong thing.
That sounds like aphasia to me.
Or apraxia or something, but I think it might just be the way I think it might be cognitive or neurological if he indeed had a stroke, as the rumors have it.
Yep, I don't know.
Roger, you've been in the field for a while. What do you think is of the state of American speech? Are kids having more problems or fewer problems than they used to have?
I would guess that overall, kids are probably doing as well as ever. There is a big increase in the number of students diagnosed with autism. Huge increase. Even when I was entering the field, well, it was 35 years ago that I started studying it. And even then, it was being noticed that there was a rapid rise in the diagnosis of autism. That would have been in the early 80s. And partly, though, in fact, I think probably mostly it's a matter of more diagnosis, not a change in the underlying rates of disorder. The diagnosis of autism was only invented in the 1940s. It took a while for people to start looking for it and diagnosing it. I also think that it's considered much more socially acceptable to have a family member have a child with autism than a child with mental retardation. I think many of the people I see now in the schools with a diagnosis of autism would have been given a diagnosis of mental retardation in the past. Now, which diagnosis is more descriptive and accurate sort of depends upon how you want to define those.
May I jump in for a second, Roger? Wouldn't you say that there's certainly a lot of kids who have autism who are cognitively really strong, who are academically advanced, in other words, who are super, super smart, but they just lack a lot of the sort of social and pragmatic skills. And they probably wouldn't be, am I right, diagnosed as having mental retardation?
No, they certainly wouldn't have been diagnosed with mental retardation. The thing with autism is that probably if you really wanted to, you could diagnose half the population with being on the spectrum. If you really wanted, because there is no objective measure, there are no objective standards for it. What the American Psychiatric Association comes out with their diagnostic and statistical manual is a set of criteria, but each and every one of those criteria are ultimately subjective. And it's just a matter of professional judgment whether the criteria gets checked off. And so I think a lot of the kids who get diagnosed with autism, who are, high level, so to speak, who are of normal or above average intelligence, would have just been sort of accepted as being kind of quirky kids in past generations. No one would have even thought to seek a psychiatric diagnosis for the person. And so, it's a hard thing to figure out how you are going to define these disorders and how you're going to draw the line between what's normal and what's abnormal.
I've noticed with the kids in the caseload I'm starting to take on in my clinical practicum, that the kids with autism, there's a pretty wide range. I mean, the ones who are really high functioning probably don't even qualify for services in the school system if they're doing well academically and they're not getting into other kinds of trouble. But there are some who they're brilliantly smart and they test really brilliantly well on a lot of the standardized tests, but they obsess on, say, for example, I give them a following directions exercise or activity, and not knowing that this one kid obsesses on drawing, I wandered into a following the directions exercise, and the first step was draw a, imaginary animal. And we had half an hour, and I could not get him to get to the next step. He would not stop drawing the animal. And this is a kid who's apparently brilliant academically, but he cannot follow directions because he becomes, fixated on certain things. So there are strange combinations of struggles, deficits, and abilities with those guys and gals.
Yeah, it is true. And I don't want to appear to be making light of the difficulties that some people face. I think we just don't know what is going on with a lot of people who aren't somehow towing the mark, following the program, doing what we expect of them. Is it a psychological thing where the child just hasn't been somehow socialized appropriately, or they've had some sort of trauma, or, I'm sure all sorts of things happen at different times in different combinations. But there is one thing I do believe, and that is that with autism, what we label as autism today is not a single disorder. What we label autism is a whole collection of behaviors that are manifesting due to a wide variety of causes. But we're putting that label on it because that's the state of our current science. That's the best we can do. We don't know what's causing it. And so all we can do is say, well, these are similar behaviors, and so we'll call them autism.
And when you work with autistic children, is there a sort of a main issue that you deal with? Is it the production of language at all that's the main issue?
Well, when you have a kid who might appropriately be dual diagnosed as autistic and mentally retarded, then just getting basic language skills of vocabulary and syntax, ability to put words together, those issues are going to be.
When you're done, I have an interesting anecdote about mutism, selective mutism, and a kid who was diagnosed with autism because he was not producing language.
Selective mutism means kids who just intermittently don't talk.
I think it has, Roger, correct me, because this is, if I'm wrong, because this is not something we've studied and may not, but I think it's mutism that's determined to have no physiological kind of explanation. So they're choosing not to talk.
Yeah, the current term, I believe, is selective mutism. Right. And it's diagnosed because in at least some, if not all, social settings, they are not motivated to talk. But it's often the case with selective mutism that there are some settings in which the child will talk. So they certainly have the physiological ability, but they are not willing to speak in other settings.
Are you guys not hearing my S's? It sounds like you thought I said elective, Roger.
Well, I honestly wasn't sure what was said. And the really confusing thing is that it used to be called elective, and then they changed the name to selective.
I never knew about the elective option.
Yeah. So because they decided that was whoever the powers that be decided
big speak.
The speech and language gods and goddesses.
Yeah. Elective mutism was deemed to be judgmental in saying the child is just making a choice about it. Although honestly, I don't know why selective is any less making a choice about it. But
exactly my thought.
I'd like to throw out one more opinion here, and that is that I'm not persuaded that concern about what to label different disorders is as important as some people think. In my profession, we've gone from labeling some people idiots, literally, that was a diagnostic label, and mental retardation, developmentally disabled, cognitively impaired, mentally handicapped, I guess is another one. We've got all these different words for it. And in my opinion, when we come up with a new label, I guess for a while you escape whatever associations have accumulated around the old label. But it isn't going to take very long for people to attach those same associations to the label if indeed it is something that is a manifestation of a disorder. So if you relabel a disorder something, it's not going to really be efficacious in changing people's attitudes because people are pretty soon going to still have the same attitude in many cases to the new label as they had for the old label.
Right. I mean, and this is true in so much of our culture.
Yeah.
How we label different aspects of our society and how those take on connotations, and then we have to change what we say.
On the other hand,
everybody has to walk on eggshells, calling things.
I mean, I think one possible positive outcome of relabeling things might be sort of the incremental message that these things shouldn't be stigmatized. You know, whenever you hear here's a new word for this disorder, it also says, because we don't want this thing to be stigmatized, this thing shouldn't be stigmatized. And so if nothing else, it's kind of a carrier for that message.
It brings awareness to the issue. Yeah.
I remember reading a book as an undergraduate called Stigma. It was required reading. And it was a really interesting book because it just talked about how there are a whole variety of things that are not valued as highly. And myself, I think it's just inevitable that people are going to make value judgments about things. I mean, that's how we function in life. We have to make decisions about what we do and don't like. And also, even if we don't make a judgment, there's no question that it's better to have an ability than to not have a skill. And so I just think that it is very much worthwhile to try to accept people for how they are. But I don't think that the way to get there is to always come up with euphemisms for things. That in a way, that almost is telling people that, well, it is stigmatizing to be homosexual. So we have to change the name because we can't use that word homosexual because that would be stigmatizing. I don't know that changing the name necessarily is going to, sometimes it does help.
I mean, in that particular case, wouldn't you say maybe for completely other reasons, it's a lot less stigmatizing to be gay now than it ever was in the past?
Oh, it's way less stigmatizing now.
Right.
Yeah. And this is a very complicated issue all of itself. You know, sometimes changing names can help people's self-image to an extent that they will then advocate and improve their lives. So I'm not going to be doctrinaire about it.
Yeah, I think I agree with you all around, though. Except that I do think there's some benefit in continuously repeatedly sending the message that it's true, it's always better to have the ability than not, but it's not helpful for anyone to be cruel about it. You know, so the acceptance isn't acceptance of, I hate to say this, the equal goodness of having a disorder, but certainly the acceptance of not treating people with those disorders as pariahs or being cruel toward them.
Absolutely. Yeah.
We try not to turn people into pariahs.
Exactly. That's my motto. Work with me. I won't turn you into a pariah.
pariah-free zone.
Yes, somebody needs a big colorful sign for their office. This is a pariah-free zone. Big rainbow.
So this went in an interesting direction.
Yeah.
But I had a selective mutism kid who turned out.
Oh yeah, tell us.
I mean, if you want or not, I'm not.
No,
You're the boss of this.
Now you have to.
Oh, okay. I'll try to make it quick. So this kid was diagnosed with autism in part because he had selective mutism. He wouldn't talk in class. He wouldn't talk to anybody at school. And the speech pathologist, who's my current supervisor, clinical supervisor, said, well, I was talking to his counselor, the school counselor who he was seeing, and the school counselor said, well, you know, when we talk in our sessions, I'm not seeing any sign that he has autism. And my supervisor said, when you talk, he talks. And the counselor said, yeah, he talks all the time, but his family he came from Russia and he has a heavy Russian accent, and he believes that people hate Russians here. So I think that in his language learning might be part of the reason he doesn't like to talk. So he was probably misdiagnosed, honestly.
Yeah, sounds like it. Yeah.
Oh, yeah, that's interesting, and relates to my question earlier about, non-native English-speaking kids and how that can confuse the issue.
But now that he's talking, his English is getting better. I see from 1 week to the next, his English is improving because he's so smart. He's a really smart kid. So he's doing really well now.
Jodie, do you have any questions for Roger about life as a speech pathologist?
How long have you been doing it? And, well, that's my first question.
Yeah, I've been a speech pathologist for over 30 years. And I've been at Albany Middle for the last, I guess this is my 9th year there. I've worked in many different settings. I've worked with people from age, I think it was 9 months up to 101 years old. And I've worked with everybody.
Wow.
One of the things I like about speech pathology is that it does have so many different settings that one can work. It's varied work. There are never 2 days that I do the same thing. Even though at the same time, there's a lot of repetition where, I'm working on some skill. I might work on the same skill for months trying to develop it. So there's a lot of repetition, and at the same time, there's a lot of variety. But I do think that working in the schools can be real satisfying. I guess what my advice is, try working in a whole variety of different settings, and and even if working, say, with developmentally disabled adults, maybe I've done that in some different settings. And even if you don't enjoy one job in it, well, maybe if you were in a different setting working with the same population, maybe you would find it would be a good experience. So
can I interject just on that point? Yeah. The 3 times I've worked with older kids, generally upper elementary or lower middle school kids with Down syndrome, I love them so much. They're just great. Ask me why if you want more information, but I won't go into it, for the sake of brevity. But I derailed you, Roger, and I have a.
I was just gonna say, try a variety of different settings, and personally, I always had the idea of keep my options open, keep the doors open, and eventually, like me, you may decide after, mid-career, I decided, what, I just like the kids so much, I'm just going to focus on them.
But I'm curious, one of the big frustrations with the school system I've been learning about is that there are laws, really stringent laws that schools have to follow when it comes to delivering services like this. But at the same time, they often don't have the proper resources, or there may even be other laws that prevent them from following. Law A might be prevented by Law B, and that can be a real frustration. My supervisor says she just does what she thinks is best for the kid as closely as possible following the law and hasn't gotten into trouble yet.
Yeah. Fortunately, sometimes being a direct service provider, you don't have to deal with as many rules. You have to do what your supervisor tells you to do. The administrator tells you to do something. If you don't do it, insubordination is cause for termination.
Right.
So
But
You
it's
got
not
it.
your lawsuit.
But on the other hand, I'm with your current speech therapist that you're working with, because yeah, you put the students' interests first. You do as much as you can what you think will benefit them the most. And I haven't gotten in any trouble doing that myself.
Good. I wonder if they're less litigious in Albany than they are in the Marin County district where I'm doing my.
Oh, I think, I mean, it's litigious everywhere, but I think it can be especially litigious when you're with affluent parents,
That was
because
my suspicion.
they've got the education to know what's supposed to be done and the resources to get a lawyer. So
Exactly. My supervisor said that parents sometimes show up to IEP, which is Individual Education Plan meetings, with their lawyers. They just show up with their lawyers because they do or don't.
Oh,
Because they either do or don't. You know, they don't like whatever the decision is that has been made about whether their kid is getting service. And sometimes the suggestion is made that their kid should get service and they don't want that. And often it's the opposite, that the kid is testing such that they don't really need the services, but the parents are saying, you know, don't you dare pull my kid from services.
yeah, I've sat in a lot of meetings with lawyers. At least in my district, if the parent brings a lawyer without first notifying the district, well, we don't hold the meeting without, unless the district has their lawyer at the table also.
Is this devolving into incredibly boring territory for you guys?
that hasn't been said.
I mean, I thought that was actually really interesting. I mean, stuff that we never think about in giving special services to kids is like all the crap you run up against with the administrations, and it's a real thing.
It's a real thing.
You know, and it's too bad. It's too bad that we can't just give our kids what they need without having to deal with all this logistical crap. And
Here's one thing I can say right now. Because of COVID, it's not possible to provide services in the way the IEP is written. The IEP is the legal contract between the district and the parent. But because of distance learning, it's not possible to uphold that legal agreement. I believe that what is likely is we're going to have years of litigation, wasting resources, arguing over what to do about that. What would be wonderful is if the legislatures would pass a law providing some political compromise that gives clear rules about what is going to be required of the districts when they can't follow all the rules. That would be great, but I kind of doubt the legislature will come through with that.
I bet there will be some form of that. There are going to be so many exceptions to so many things because of COVID.
Yeah.
I have one more question that I'm just curious about for Roger. Have you had kids on the spectrum with, say, obsessiveness or just no motivation to be socially aware that you've been able to make a lot of progress with? And how? What did you do?
Yeah, well, that is the hallmark of autism. That's really the central disorder. And what you do is you make whatever connection you can with that student, and then you try to expand upon it. So try to get the kid to at least engage with a toy with you, where you take turns acting upon this toy, so that you get some kind of reciprocal action going on, where they do something and you do something, and they do something and you do something, where they begin to, in that way, interact with you. And depending upon their cognitive level and the degree to which they are socially withdrawn, you build on whatever behavior they have to expand their repertoire. You do it in small steps with reinforcers, the whole variety of things you might do depending on the situation.
Right.
Might provide them with breaks.
Hmm.
Sometimes, provide them with something that they especially want if they will request it.
Right. That's sort
You
of the
might,
behavioral aspect of it.
yeah, you might provide them with a defective toy so that they have to ask to have it repaired in some way. Give them, I don't know, there's just a whole variety of things you might do to get them to engage with you.
It sounds like you're starting with really, really young kids. I have this, that suddenly inspires a handful of follow-up questions, but I'm curious, one, if that's relationship development intervention, which I had not learned about in school, but I've learned about from my clinical supervisor, and it's super interesting. It essentially, I'll back up. She said that she's getting a lot of these kids, and they have a lot of exercises where they'll ask, what does it mean to be a thinking of others person, or show them show pictures to the kids and say, what is this person thinking? What do you think they might do next? And the kids are fantastic at these exercises, but they can't do it in real life, or they don't do it in real life. And she said that what's happening with a lot of these kids is that there's this thing called relationship development intervention, which I guess might be a little controversial because it hasn't had a ton of research to back up.
I never heard of it before.
Oh, check it out. So I'm convinced unless I see some research refuting it. But she said that a lot of these sort of really fundamental skills, which you were describing like joint attention and things that kids typically learn when they're infants. They start learning as infants, as little kids, and it just happens naturally as a little kid. But for kids who are not neurotypical, they might not be learning these fundamental skills that most kids are learning, infants, toddlers. So they get to be 7 or 8 or 9, and they've got the intelligence to memorize all these words that they're supposed to say, like, oh, that person is happy, thinking of others means this, but it doesn't. But if they don't have these fundamental skills, it's not going to click. So there's this program called Relationship Development Intervention, RDI, which has a therapist component and a take-home component for the parents to do, that takes them through these steps of basic social skills development. And some of them have to do with, say, the family should spend half the day using only nonverbal communication, using joint attention in nonverbal communication and things like that. It's just really interesting to me. I think it sounds right to me. What do you think?
I'm gonna just intervene in a socially awkward way here and suggest that we reach an ending at some point soon.
Oh yeah, shoot, I should go too. Good hosting there, Amy, aka idiot.
Yeah. I'll just very briefly say it sounds promising, but I don't know anything about it, so I can't comment further.
Yeah. Yeah. In that case, I conclude my comments socially awkwardly.
Yeah, you guys totally need to get with each other outside of this venue and continue the conversation. It sounds like.
Sounds good.
Thank you for joining us today, Roger, and thanks for both Roger and also Jodie for joining us halfway through.
Really interesting stuff.